Howdy, y'all. I'm Dr. Jeff Jarvis, and this is the Pre-Hospital Blood Administration Protocol Review module. This is the protocol that covers the indications for the pre-hospital initiation and administration of blood. We're not talking about blood that's already hanging on an IFT. These are 911 calls. Our primary blood supply and what we want to carry is whole blood. That's the stuff that's bleeding out of our patients. It has all the goodies. It has the red blood cells. It has the platelets. It has the plasma. All the things. Now, this is different than component therapy, which is a bag full of just one of the goodies. Now, why do I tell you that? Well, because if we find ourselves in a situation where our supply of whole blood is limited, we're going to give red blood cells and plasma. This protocol authorizes administration of either one of them because we don't want to have to keep updating the NAM protocol if we can't get whole blood. We're hoping we'll always have it, but we just want to authorize both in either case. Again, we hope we're going to keep the good stuff on hand. All right, before we get started, let's talk about the good stuff, and specifically, let's talk about blood types. I just want to make sure we're all on the same page about what we're carrying. Blood cells have antigens. They're the little flag-like things, and the antigens are what give the type. Type A, for example, has the A antigen. B has the B antigen. AB has both A and B, and type O has none. Blood also has antibodies, and those antibodies react to the antigens. Type A blood has anti-B antibodies. B has anti-A. AB has neither anti-A nor anti-B, and type O has both. Now, when matching antigens and antibodies meet, let's say, for example, type A blood is given to a patient with type B blood, the recipient's anti-A antibodies are going to react to the donor's A antigens, and that's going to cause a reaction. It's kind of like matter meeting antimatter in Star Trek. It is bad news. The blood clumps up and causes all sorts of clumpy problems. There's also the Rh antigen. That's the thing that gives the plus or the minus. O neg means there is no Rh antigen. O positive or A positive means in addition to the A antigen, there's the Rh antigen. Now, O negative is the universal donor, but it's kind of rare. O positive, on the other hand, is way more common than O negative. And there are some folks out there that have very low levels of Rh antigen, and we call these antigen levels titers. So we would call this low titer, and low titer blood doesn't necessarily cause some of the same problems as high titer blood. So the stuff that we're going to be carrying is specifically low titer, O positive whole blood. Now, one of the primary concerns with giving Rh positive blood to a patient who's Rh negative has to do with pregnancies. So if a woman with Rh negative blood is exposed to Rh positive blood, they can then make anti-Rh antibodies. And the next time that woman is exposed to the Rh blood, like maybe exposed by a fetus that's Rh positive, well, the antibodies she made last time can now react to what the body sees as foreign blood and cause reactions or even miscarriages. Now, we're less worried about this in our setting, really for two reasons. And the first is sort of obvious. We give blood to patients who are dying from hemorrhagic shock, and you kind of have to survive that hemorrhagic shock in order to live long enough to have a reaction. Second, even if there is a reaction, if the patient survives, there are ways to treat it and prevent the development of antibodies. And then the third reason is low titer part. That means there's less of a chance of an issue to begin with. All of that is to say that we're going to be giving low titer O positive whole blood, and it's safe. Our OB colleagues and our blood pathology colleagues are all on board with this, and they support us. Let's talk indication. So the indication for giving blood is pretty simple. It's hemorrhagic shock. The stuff they need is now dripping out onto the ground. Now, that can be from trauma or medical reasons, and common medical reasons are GI bleeding and then sometimes postpartum hemorrhage. Our specific criteria here requires that you think their shock is from acute blood loss and they have the following vital signs. So, all by itself, a systolic less than 70, that's all you need, give it. If you have a systolic greater than 70 but less than 90, then you need a high heart rate. So systolic less than 90 and heart rate 120 or above. And then the last criteria is they're 65 years of age or older, and they have a systolic of 100 or less with a heart rate of 100 or more. So those are the vital signs. Levi has put them up here on the screen. Those are our vital signs. So you think the hemorrhagic shock is because of acute blood loss, and they meet one of the vital signs criteria. Now, the final criteria here is one that is actually fairly rare, and that is traumatic cardiac arrest. And I don't mean traumatic cardiac arrest is rare. I mean the criteria to give blood in traumatic cardiac arrest is rare. And that is because most patients with traumatic cardiac arrest are not going to be salvageable just by giving them blood. And very frequently, we will get there too long after anything we can do can make a difference. So, final criteria, traumatic cardiac arrest that is witnessed by EMS. Has to be witnessed by us. And, this is the really hard part, and the blood can be flowing. And I'm not talking about just arriving on scene. I'm talking about the blood can be going in the patient's arm in under 5 minutes from arrest. Other traumatic arrests are just not likely to benefit from the blood and would just end up wasting this precious commodity. So, only give blood in traumatic arrest if you saw the arrest and that blood can be going in the patient within 5 minutes of arrest. You basically have to have it already set up, have the line in there, have the blood ready to go, and then they arrest. Now, for any of these patients, regardless of criteria, if they meet the criteria, you're going to give the blood, you're going to give 1 unit of low titer O positive whole blood. If we don't have whole blood, then you're going to give them a combination of 1 unit of packed red blood cells, PRBCs, and then 2 units of FFP, or fresh frozen plasma. Now, this combo isn't as easy as just giving 1 unit of whole blood, and it turns out it's not as good. We like to put back in what's coming out. So let's hope we maintain a good supply of this blood. Speaking of supply, one way to ensure there's a good supply is to donate yourself. Please donate blood if you're able to. And if you have O positive blood, please let the blood bank know. And you're going to have merch raining down upon your head. You're going to be in a veritable field of Oreos. You're going to have thankful patients and repeat requests for donation as far as the eye can see. Seriously, guys, you can be a real hero even when you're not working, because you're obviously all heroes when you're working. So please, guys, seriously, go donate. We need the blood supply. Our community needs the blood supply. Now, the last thing here is anytime we give blood, we're going to give 2 other drugs. We're going to give calcium and we're going to give TXA. Fortunately, it's 2 grams of both. And we know why we're giving TXA. TXA helps slow down the natural breakdown of clots. That's why we give it to all patients with ongoing bleeding. Calcium, though, is kind of interesting. So it turns out blood in a bag has a tendency to clot, and that's bad. We need to give it things to not clot. Citrate is one of the things we add to the bags to help prevent clotting. Unfortunately, though, when a lot of blood is transfused, the citrate goes with it, and it can bind to the patient's own calcium, lowering their calcium levels. And that's why we give calcium. We're replacing what's getting bound up by the citrate. Now, because blood is in such short supply and because it has a limited shelf life, and because it requires meticulous temperature management and paperwork, we're only going to be carrying blood on some units. The medics carrying blood, they're going to go through specialized training in how to prepare and administer the blood, how to maintain the blood before they give it, and how to do all that really fun paperwork that all of us went to paramedic school to give. If you're not one of these medics, this protocol we're just talking about, this is what you need to know. For those out there that will give blood, don't worry, because there will be additional training set up to go over the policies, the procedures, the other stuff, all the rest of the details about how to actually give the stuff. And with that, let me please beg you one more time, go donate blood. The gift you give can truly be the difference between life and death. Thanks for listening, and as always, thank you for all you do to care for our community every single day. Take care, y'all.